So welcome back, everybody. This is part 2 of our webinar 1. So in part 2, we're going to consider European guidelines, recommendations for MDT working and nursing roles, overview of treatment and treatment guidelines, the impact of a cancer diagnosis, and we're going to include an overview of surgery. And we're going to include surgery in this part because most people have surgery, and it means that we can focus on adjuvant treatment in the next webinar. So I'll hand you over to Mandy.
Let's start by looking at some of the guidelines. The first European Breast Cancer Conference in 1998 produced a consensus statement based on increasing evidence that multidisciplinary team care improved outcomes. They recommended that all women should be treated in a fully equipped, multidisciplinary and multi-professional breast centre. And you can see the 2020 version of the guidelines here on the screen. And if you haven't seen them, it's really worth having a read through because they are very helpful and very educational. So the current guidelines lay out the requirements and expectations of care in a specialist breast unit. And they look at the MDT structure and function, the recommended minimum caseload, and that's for every breast team to see at least 150 new cases of breast cancer each year. They give detailed descriptions of the skills and expertise needed by MDT team members. They recommend the involvement of patients or advocacy groups in service development. They look at collection of high quality data, and they have a focus on education and research. Having said all this, a review in 2020 showed that only 55% of European countries have functioning MDTs, and access to these MDTs varied a lot within those individual countries. So within the guidelines, these are the mandatory core members of an MDT. So a breast surgeon, breast histopathologist, breast imaging or radiologist, breast care nurse specialist, medical oncologist, clinical oncologist, and a breast data manager. And we'll look at the role of each one in more detail in the next slide. So let's think of it in the context of the role each core team member plays within a multidisciplinary team meeting. So surgeons assess and present the clinical presentation or response to primary or neoadjuvant treatment to determine what surgery is technically possible and make those recommendations. Radiologists or imaging specialists assess and present the extent of disease in the breast and metastatic spread where appropriate. They also assess the degree of response to primary treatment where patients have had maybe primary chemotherapy or endocrine therapies to see if the cancer has shrunk to facilitate breast conserving surgery. Histopathologists describe the pathological features of the tumour, including size, type, grade, and the receptors, so the ER, the PR, and the HER2 receptors that we talked about in the first part of this webinar. Medical and clinical oncologists recommend and manage systemic therapies and radiotherapy treatments. And breast care nurses use their knowledge of patients and patient preference to act as the patient's advocate in multidisciplinary team discussions. And we'll look at what the European guidelines say about the breast cancer nursing role in this next slide. The guidelines say that there should be 2 specialist nurses with breast cancer training in each unit. Now that's quite challenging when we don't have good access to specific breast cancer training for nurses across Europe. Each nurse should see a minimum of 50 new early breast cancer cases and 25 advanced breast cancer patients each year. The nurse should be available to support patients from diagnosis and throughout their pathway, offering emotional support and practical advice. They should be able to offer explanations of treatment plans and give information about managing side effects. They should play an active role in developing pathways, protocols, and information with other team members. And the last point, recognise the unique relationship nurses have with their patients and the importance of nurses documenting their interactions with patients so they can share that information with other team members, and that patients' preferences can be considered when we're making treatment recommendations. It's also important to acknowledge that there are many extended members of a breast MDT, and that patients with early breast cancer may need to interact with lots of different healthcare professionals. Some of the extended MDT members may include people from psychological support services, plastic surgeons, physiotherapists, lymphedema specialists, clinical geneticists, menopause experts, and people from palliative care teams. It's important to remember that a cancer diagnosis affects everybody differently. You will have all seen really different responses from people when they receive difficult news, and this can be anything from absolute despair and devastation to someone who presents as almost in a matter-of-fact kind of way, and they're managing their illness as a project to help them cope. People may face short-term physical challenges while recovering from surgery or undergoing chemotherapy, while other people may develop longer physical consequences of their treatments. Many people face emotional challenges when faced with a cancer diagnosis, and there are practical challenges in maintaining roles within the family and managing everyday life. Dealing with these challenges can lead to a difficulty in hearing or processing information to inform decisions about treatment. I want to just talk a little bit about male breast cancer. So we've already said it's rare, and it accounts for about 1% of all the new breast cancer diagnoses. It's really important to remember that the impact can be absolutely devastating for a man and his family. Men can feel stigma or shame for having a woman's cancer, and they commonly feel that breast cancer services are not designed for them, and we really need to be mindful of this. I can remember men sitting in my clinic when I was diagnosing breast cancer, surrounded by women and leaflets that are all in pink and very, very feminine and female orientated, and we don't do this well. Female partners can feel guilty as they think it should have been them who have developed the cancer because it's a female cancer. Children can be embarrassed of their dad having breast cancer. There's a higher incidence of genetic breast cancer in men, and therefore genetic testing should be offered. Information and support is really important to ensure that people and their families fully understand the implications of the genetic testing process. You can hear firsthand from Tony in the symposium recording that I mentioned at the start of this webinar about his experience of being a man with breast cancer, especially the issue of not really understanding the implications of undergoing genetic testing for his family members. The ESOMA guidelines are clear that healthcare professionals who deal with cancer patients and their families are recommended to have training in and knowledge about communication skills. Patients must be offered clear, verbal and written information which describe the diagnostic and treatment options. They should be given information on local support groups and national advocacy organisations who may be able to offer further support. Good communication enhances relationships between healthcare professionals and patients and their families. It enables patients to hear and digest information to enable informed decision making and to help them cope. So we've looked briefly at the impact of breast cancer diagnosis, but let's have a think about other things that can affect how somebody may cope with their diagnosis and treatment. Cancer doesn't happen in isolation, and many people have other difficult challenges in their lives. For example, they may be going through a divorce or have problems at work. Previous experience of cancer is important. If the person has only ever seen negative outcomes or has a poor experience of treatment, this is going to affect how they feel and cope. Many people may have comorbidities that are already impacting on their quality of life. They may be a single parent or have care and responsibilities for a disabled child or an elderly parent themselves. We live in multicultural societies, and it's important that we understand factors and beliefs that may impact on how people access and experience the services that we offer. If somebody has anxiety, depression, or other mental health problems, A diagnosis of cancer may make this worse. It's important to know what support people are receiving and let them know what's available to them. So holistic assessment of our patient needs is so important so that we can understand individual needs and how best to support people. It's extremely easy when we're really busy to bring our own agendas when meeting with patients. For example, when meeting a patient to discuss their first chemotherapy treatment, we have a lot of information we want to give them. But it's really important to think about what the patient may be worried about on that day and what's important to them. If we don't address their worries and concerns, they may not be able to hear or process the information we want to give them. So we need to shift our thinking in interactions with patients away from what's the matter with the patient. So this woman with breast cancer who's starting chemotherapy, and to focus on what matters to them. What's important to them today? What are the things that are worrying them? And that's the way we facilitate good holistic care. These are the ESMO clinical practice guidelines for the management of early breast cancer. There are also guidelines for the treatment of advanced breast cancer. We'd really recommend you having a look at these if you're not familiar with them, and they're a great educational resource. And if you Google ESMO interactive guidelines, you'll find them very easily on the internet. The guidelines contain evidence-based practice standards on diagnosis and pathology, staging and risk assessment, surgical treatments, neoadjuvant treatments and adjuvant therapies, personalised medicine, and the importance of treatment recommendations being guided by receptor results and genomics where appropriate, follow-up protocols, and advice on rehabilitation and the management of consequences of treatment. So we're going to have a look at, give an overview of the treatments that early breast cancer patients may have. The majority of people will have surgery at some point in their treatment pathway. Some people will still require a mastectomy, but there is a wide range of oncoplastic procedures to facilitate breast conserving surgery nowadays. Women undergoing mastectomy should be offered breast reconstruction, but they must have realistic expectations about what can be achieved. And we're going to talk about surgery in more detail at the end of this webinar. Many of you will be working in areas where you administer chemotherapy and targeted treatments. Some people will receive neoadjuvant treatment to shrink tumours to enable breast conservation treatment, or because they have triple negative or HER2 positive cancers and we want to give them chemotherapy upfront. Others will receive systemic treatment in the adjuvant setting to reduce the risk of recurrence. Radiotherapy to the breast is a standard part of breast conservation treatment. Some patients may be recommended radiotherapy to the chest wall or the axilla following mastectomy, dependent on their pathology results. All patients who have hormone receptor positive breast cancer will be recommended hormone therapy to reduce the risk of recurrence and in some cases of a contralateral new primary. The choice of hormone therapy is dependent on menopausal status and other clinical factors. Finally, many of you will be aware of the use of bisphosphonates to treat osteoporosis and bone metastases. Research has shown that they may also reduce the risk of developing bone metastases in some postmenopausal women who are at high risk of recurrence. So as you can see, the multimodality treatment pathway has become more and more complex, and some women will receive all of these treatments. So let's see how this looks on the ESMO early breast cancer treatment algorithm. It's quite a busy slide, but hopefully I can explain it clearly. There are three main pathways. Those who are not triple negative or HER2 positive and have small tumours that are suitable for breast conserving surgery, which on the left-hand side of the screen, proceed with surgery as their first treatment. Those people whose tumours are not triple negative or HER2 positive and do not want breast conserving surgery, go ahead with mastectomy with or without reconstruction. This is on the right-hand side of the screen, and this group also proceed with surgery as their first treatment. The third group are those people who have larger tumours, which would be suitable for breast conserving surgery if the tumour can be downstaged or have a triple negative or HER2 positive cancer. These group receive neoadjuvant treatment, usually chemotherapy, with the addition of trastuzumab and pertuzumab in HER2-positive patients. Where chemotherapy has been used to downstage a tumour, if there is a good response, then people may have breast-conserving surgery. But if not, mastectomy will still be the recommended treatment after chemotherapy. As the algorithm shows, people who have surgery for their first treatment will be recommended further adjuvant treatments based on pathology findings. As previously mentioned, radiotherapy is mandatory after breast-conserving surgery, but it may also be recommended to the chest wall or axilla after mastectomy for large tumours, those tumours that are close to the chest wall, or people who have heavy lymph node involvement. The decision about whether adjuvant chemotherapy is recommended is based on final pathology results, including size and grade of tumour, the presence of vascular invasion, and lymph node involvement. People who have hormone-positive cancers will routinely be recommended endocrine treatment for 5 to 10 years. The treatment pathways for early breast cancer have become more complex, and this reinforces the need for the multidisciplinary team discussion and management. For that reason, we will cover surgery next in this webinar, and in the following webinar, we're going to focus on systemic therapies and radiotherapy. So as we've said, the majority of people will have surgery as part of their early breast cancer treatment. This may be as their first treatment or after primary or neoadjuvant systemic therapy. The aims of surgery are to remove the tumour, to achieve clear surgical margins, and this is checked by the pathologist in the lab when the surgical specimen is sent to the laboratory, and to reduce the risk of a local recurrence. The ESMO guidelines state that the preferred treatment for early breast cancer is breast-conserving surgery, but there will be clinical indications where mastectomy is recommended, and we'll talk a bit more about this later. They state that the sentinel node biopsy is the standard of care for axillary staging, and are clear that reconstruction should be offered to all women undergoing mastectomy. They give guidance on the management of DCIS, which can be treated by breast-conserving surgery, providing a minimum of a 2 mm margin is achieved, so a clear rim of cancer-free tissue. Otherwise, mastectomy would be recommended. And they also state that occult breast cancer, which is when breast cancer cells are found in the axilla, but the primary cancer cannot be identified in the breast, should be treated with axillary clearance and whole breast radiotherapy. I want to quickly talk about localization, and this is something that comes up with patients that are often diagnosed through screening, or people with very small cancers that we see on mammograms when they come into a symptomatic clinic. So when tumours can be seen on imaging, but it's not possible to palpate them in the breast, the area needs to be localized either by insertion of a wire by the radiology team or insertion of a radioactive seed-on marker prior to surgery. This enables the surgeon to identify the area to be removed at the time of the operation. And you can see in the picture of a wire that's been put into an imaging abnormality there on the breast. Clips or markers are usually inserted into tumours prior to people starting neoadjuvant systemic therapy as well, to ensure that it's still possible to identify the original site of the tumour if there's a good response to treatment. And this means the tumour is no longer palpable. So then the clip is used to localise where the cancer was originally, so that when you do the surgery, you can take out the right area of tissue. It's a really important thing just to think about. If we can't feel it, we need to be able to find it when we do an operation. Breast-conserving surgery is the preferred local treatment option for most early breast cancer patients. This is sometimes called wide excision, and is in essence removal of the tumour with a rim of healthy breast tissue around it. With the use of oncoplastic techniques in cosmetically, technically challenging cases when needed, it's possible to remove larger areas of breast tissue and still achieve good cosmesis. Careful histological assessment of resection margins is essential, and it's important that there is no tumour at the inked resection margin where the surgeon marks the edge of the tissue before it goes to the laboratory, and there's more than 2 mm of healthy tissue around site for disease. If clear margins are not achieved at the time of surgery, and the pathologist says that there's cancer at the margin or very close to the margin, the patient will need another operation to either remove another area of tissue and that to be checked again to make sure that's clear of cancer, or the patient may actually still need a mastectomy. So mastectomy involves removing all of the breast tissue and in most cases the nipple. The clinical indication for mastectomy are large tumours, extensive DCIS throughout the breast, skin involvement, multifocal disease, which means that there's cancer in more than one area of the breast. And it's really important to think about patient preference, because there are some women that prefer to have mastectomy rather than breast conserving surgery and radiotherapy. Breast reconstruction should be available for all women requiring mastectomy. Immediate reconstruction is suitable for the vast majority of cases, except those with inflammatory breast cancer. There are many reconstruction techniques, either using implants, which is the top picture here on the right-hand side, or autologous tissue from other areas of the body, for example, abdomen, thigh, back or buttock. The picture at the bottom, the lady has had autologous tissue taken from her abdomen and used to reconstruct her breast. The optimal reconstruction technique for each patient should be discussed individually, taking account of the patient's anatomy, treatment and patient-related factors and preferences. So some women may not have enough tissue on their tummy to move up to rebuild breast tissue. Some people may be having radiotherapy after their treatment, and to think about the impact of radiotherapy on a breast implant. And some people have a very strong view about the type of reconstruction they want. So it's about balancing all of these factors during the discussion. What's very important is that women have a realistic expectation of what can be achieved, as no reconstruction replaces the breast that they've lost. And often women's only experience of breast surgery is of breast augmentation, and so they can have very strange expectations of what's going to be achieved. And so it's really important to show photographs of different types of reconstruction, explain what is possible for them and how it may look. Sentinel lymph node biopsy is the standard of care for auxiliary staging in early clinically and radiologically node-negative breast cancer. Until recently, all patients who had a positive sentinel node result would then have a full auxiliary clearance. You can see a blue node on the screen there, and that's because the patient's been given a blue dye injection into the breast prior to her surgery, and that dye has then tracked until the sentinel node, which is the node that the lymphatics drain into through the breast, and that helps the surgeon identify the node to remove at the time of surgery. Further auxiliary surgery following a positive sentinel node is not always required for low auxiliary disease burden. So for micrometastasis or just one or two sentinel nodes containing metastases can be sometimes be treated with post-operative tangential breast radiotherapy. Auxiliary radiotherapy is a valid alternative in patients with a positive sentinel node, irrespective of the type of surgery. So it doesn't matter if they've had breast conserving surgery or mastectomy, it can still be considered. And people who've had a positive lymph node at the time of their triple assessment will all be recommended to have a full auxiliary clearance. So let's think about the information, support and care people require after breast surgery. There's some really practical things. So most people will need analgesia for the first few weeks post-surgery. Some people can develop a horrible nerve type pain under the arm and across the chest wall. And for some people, this could become a chronic problem. People will need advice about wound management. A lot of breast surgery is performed as a day case. And so it's important that people know what to expect, what to do, and who to call if they're worried. It's very common to develop a fluid buildup under the wound, and that's the top right photograph there following breast surgery. This is called a seroma, and it's a normal part of the healing process. Some people don't develop any fluid and some develop a lot, like the lady in that picture. Some people who develop large amounts of fluid can find that there's pressure put on the wound, and sometimes the wound will leak and it can cause pain and discomfort. There is controversy about the use of surgical drains and whether seroma should be drained with a needle. Each situation needs to be assessed and the risks and potential benefits discussed with the patient. Information about arm exercises and assessment of arm mobility are a vital part of post-op care. It's essential that people are able to lift their arm over their head to achieve the position required to deliver radiotherapy to the chest wall or breast. So very practical things. We want people to be able to use their arm after and get back to normal after their surgery, but they also need to be able to do that to be able to receive breast radiotherapy. After surgery, some people develop a tight cord of tissue under the skin, causing breast and causing pain and restricted arm movement. Sometimes the cord is visible, but it's not always visible, but you can usually feel it as like a long piece of string running down the arm. It can appear even months after surgery, running to the area under the arm. No one's sure what causes cording, but it may happen when lymph vessels, which carry lymph fluid from the arm, become hardened. Stretching and massaging the cord can improve symptoms, but people may need help from a physiotherapist to manage this. Information about the risk of lymphedema and strategies to reduce this should be a mandatory part of care for people undergoing surgery to the axilla. We'll talk more about lymphedema in webinar 3. A soft breast prosthesis should be offered to all women immediately after surgery to use until their wound is healed. A silicone heavier weight prosthesis should be offered 6 to 8 weeks after surgery. And it's really important to think about offering prosthesis in appropriate skin tones. It's something I feel really strongly about, and there's a lot of worry that not everybody has access to something that's appropriate for their skin tone. Finally, let's think about body image. This is not just about women who've had mastectomy. Some women have real difficulties in adjusting to changes in how their body looks and feels after breast conserving surgery as well. And we'll talk more about the impact of this in webinar 3. So in the second of our 3 early breast cancer webinars, we're going to focus on treatments in more detail. We'll be taking a closer look at systemic anti-cancer therapies in early breast cancer. We'll look at radiotherapy to the breast or chest wall. We'll look at endocrine therapies, bisphosphonates, and how to recognise emergency situations and to manage the effects of treatment. Hope you've enjoyed this webinar, and we're going to move on to take some questions.